Thank you all for being here tonight on this very cold Melbourne evening. I did just recently submit my PhD, so today I'm going to present some of my study findings and then some of the overall implications of the PhD work. So I'll begin just by acknowledging the Wurundjeri people, the traditional custodians of the unceded land on which I present from today here in Naarm. I want to pay my respects to elders past and present from this region and also from the lands from which you might be joining from. So a little bit of background, I guess, to physical activity and cerebral palsy. Back in 2016, Vashiran and colleagues released some physical activity guidelines specifically for people with CP, and they're actually quite similar to the guidelines for the rest of the population, and that's strength training twice a week and moderate to vigorous physical activity about 150 minutes a week, which is about half an hour most days. And these are the recommendations for most people to mitigate health conditions like diabetes and heart disease and maintain strong and healthy bones and muscles. So since then, there's been many studies to demonstrate that for most adults with CP, meeting these exercise guidelines is quite difficult, and that this group is generally less active than the rest of the population. And there's a particular drop-off in activity levels during adolescence and then early adulthood. But in addition to physical activity, there's also health risk associated from sedentary behaviour. And as you can see here, people with CP across all mobility levels or GMFCS levels often spend more than 70% of their day sedentary. And while a lot of the physical activity intervention research focuses on trying to achieve those physical activity guidelines, there is a whole other body of research that's emerging that shows that really any reduction in this sedentary time is going to have health benefits as well. So some activity is always better than none. And on top of that, really any level of activity can have a positive influence on things like mental health or quality of life. And over the past decade, adults with disabilities are increasingly reporting that things like mental health, enjoyment, and social reasons, are increasingly motivators for their physical activity. So coming into this PhD, my own background is as a physio, and I work 2 days a week in a specialist health service supporting young adults with CP to transition into adult healthcare. And when I started my PhD, the NDIS was really only just rolling out, so most young adults didn't have access to regular therapy, and a lot had lost the structured activity that they might have found support for during their school time. And then as they started to get older, in their late 20s, early 30s, a lot of the young adults would start to report changes to their walking, and they might have more falls and experiencing some sort of decline in their physical function. So one part of my role was really to try and support increased physical activity for this group. And the issues that we ran into were firstly that there is very few options for adults with a disability, and then there's even fewer options for those who might require adaptations for a physical disability. But there are gyms pretty much everywhere, and this became a common option that we would work with young adults towards. And I do totally recognise that gyms are not for everybody, but there are a few good cases for looking into this setting. So in national surveys of people with disability, it is consistently rated in the top 3 as a preferred place to exercise, with the other 2 being swimming, like in a pool, and walking in the community. My own experience was also that the equipment in community gyms actually generally is adaptable to a variety of needs. And most local government areas have a council-owned or operated gym. So gyms are quite geographically accessible. Across the world, they're also one of the most common settings for young adults to be active. So it's kind of a normal place to exercise as a young adult. And most importantly, when we talked to young adults with CP, they told us that they wanted to be like other people that go to the gym. They had friends that went to the gym, and they wanted to get out of the house and just do something that everybody else does. But although the gym seemed to be a desired place to exercise and a good option to look at, we often found barriers to participating in the gym setting. And so the overall aim of my PhD was to try and understand what was influencing participation in community gyms and what strategies or supports could potentially facilitate their involvement there. And so I completed 4 studies as part of my PhD. I had a systematic review to find out what literature was out there, a qualitative study with young adults about their experiences in the gym, a Delphi study, which was to try and determine what the priority areas might be to address, and then another qualitative study, but this time with gym staff, and that was to try and understand their experiences of providing support to young adults. So I have already presented the first 2 studies a number of times at CP-Achieve events, so I'm not going to spend too long on those, but I'll focus on the final studies and the kind of overall thesis findings and implications. So as my thesis was really about trying to understand the state of play and the perspective of young adults, it was important to me that their voices were prioritized and drove the findings, because ultimately it's their participation that I was hoping to influence. And so I did this in 2 ways in my thesis. The first one was through some methodological decisions. And then the other one was through consumer involvement. So on the right here, I've just got a picture of the consumer involvement ladder, which provides, some of the levels of involvement that a consumer might have in research. And so my studies utilized primarily consultation and involvement through consumer advisory groups. And then for my Delphi study, I had 2 young women with CP who were co-researchers and equal partners in the research team. So they were collaborating with me on that project. And consumer involvement in research was really quite a new concept to me, and it's not very common in physio research, but it is starting to become more and more expected, and obviously quite a big feature of the CP-Achieve project. So I do know I'm preaching to the converted here, but I found working with consumers in my doctoral work to be really valuable, and not just for the studies themselves, but also for the professional skills, like in my clinical practice, and then my research skills for being able to coordinate, I guess, a team, and also a team that might have differing viewpoints and differing sort of life experiences. So I'll just summarize quickly the findings from the first 2 studies, the systematic review and the qualitative study with young adults. We did find a number of factors that were influencing participation in physical activity and in the gym setting. And I think from research that's gone on with other disability groups and my own clinical experiences, it was not entirely surprising to see things like the physical environment and cost coming up as barriers. But what I guess was really interesting or new was just how big the social environment featured as a factor in participation and in the minds of young adults, particularly in that first step into physical activity or the gym. So there was a lot of worries about starting exercise, doing the wrong thing, or the sense of belonging within the gym setting. But importantly, the experiences within that social environment could be modified by things like positive social connection or the provision of social supports, which was usually from families, peers, or logistical support from disability programs. And I guess that these experiences and perceptions of the gym environment could be changed without actually changing the physical nature of the gym itself. So it was really just about changing the way that the young person interacted within that gym environment. So following on from that, I wanted to try and identify what's next, what needs to be changed in the gym. And to do that, I completed a Delphi study, which is basically bringing together people who are considered experts in an area to try and reach some agreement on a topic. So in this case, it was what is the priority, or what are the priorities to improving gym participation? So we asked young adults with CP and their families as experts in their own experiences. We asked gym staff, and we also asked health professionals to take part in this survey. The first round was an open-ended survey, and we asked everyone to basically suggest what they thought needs to be done. And we got over 900 suggestions, which I guess just goes to show how much potential for change there is in this area. But there was a lot of overlap in the suggestions. So with the help of our consumer advisors, we did narrow these down to 83 strategies or ideas for change. So then we asked the same group to rate the ideas on how important each one was to implement. And we kept the idea on the list if 70% of the participants rated it as highly important. So then in that round, we ended up with 54 strategies that were highly important, and there was quite a number that were kind of on the borderline. So we asked the group to rate them again, and 44 made the final cut. And it's probably important to note here that we did seek to give further weight to the young adults' responses by ensuring that anything that the young adult group rated as highly important, if it met 70% of the young adults rating it highly important, we kept it in, even if it didn't get to 70% across all the groups. So this is quite a busy slide. It does have the 44 ideas on it as abbreviated bubbles there, and the agreement percentage is up the side here. So anything that's at the top is the highest agreement on importance, and they're categorized roughly into the socio-ecological levels of influence, just for analysis. So here I've just summarized again some of the findings from the first two studies, and the main thing I wanted to show here was that a lot of those key findings were reflected in the priority areas. So we can see that the physical environment features quite strongly. Cost-related factors primarily related to the use of NDIS funds, as obviously the main disability funding here in Australia. And then the social environment of the gym included things like accessible information or representation in marketing, and we start to see the importance of the gym staff knowledge and training as an influence within that social environment. And then in addition to the gym staff, we can see that other social supports, like from support workers, parents and health professionals, are also important to young people with disability and their support networks. But I guess one thing that I do want to point out is that one-on-one support in the gym was considered highly important to all the groups, or having the option of one-on-one support. But all of the participants were able to suggest who they thought, these supports could be. And we had families, therapists, gym staff, peers with or without disability, and support workers all suggested, and none of those actually reached consensus across or within the groups, just with the exception of young adults with disability putting in a highly important preference for being able to exercise with the gym staff. So now we have some idea of some of the important strategies to all of these groups. What are the gyms actually currently doing to support young people with disability to take part in their environments? So in my final study, I interviewed 25 gym staff who worked across 29 gyms in Victoria, being any gym that is council owned or operated. And we wanted to find out what social supports are in place to facilitate participation. This study did contribute to a larger body of work that was funded by Vic Health, and it's called Gym Spark. And through that project, we had a disability advisory group and people with lived experience and representatives from the leisure industry on the steering committee as well. So when I'm talking about social support here, the definition that we used was quite a broad definition. It does extend to things like emotional supports, instrumental supports, informational support, and appraisal support. So it's not really just about having someone to exercise with. And this definition is also reflected in the broad range of support types that we identified during a scoping review that we completed. So prior to my interviews, we did a scoping review looking at what social supports are being used in gym intervention trials that are, research trials but being conducted in gym settings. And we identified 8 support types. So there was logistical supports, orientation, specialist support, supervision, motivational supports, peer supports, social activities, or education. So what is actually happening in community gyms at the moment? I found that social support could be provided as part of like a standard support. So things that are available to anybody in the gym. They could be an inclusion related support. So something specifically for people with disability. And they could be an external support. So those were things that were provided by external parties, but being implemented within the gym setting. And most commonly, gyms were utilising orientation, specialist support, or supervision. And although it looks like there's a lot of things being offered on the slide here, I do need to point out that they weren't offered across all the gyms by any means. So there was a lot of variability in what was available across the state. But they do represent options that have been able to be implemented in practice. Then in terms of how the supports were provided, there was really 2 key things. And the first was about phases of support. So first, you have to get into the door of the gym. Then there's a whole getting started process before you actually get into your ongoing participation. And social support can be provided at any point along those phases. But when we looked at the types of support being provided by gyms, they're much more heavily weighted to once somebody is already involved in the gym or in a program. And there's not a lot of support or variety of support being offered in the really early stages of interaction, which is quite different to how research programs operate in the way that they often really support that early engagement. And then the key factors that were influencing the availability of social supports related to people, partnerships, and policies. So people usually related to passionate people within the gym or having a dedicated inclusion role. And those were the people that really drove the availability of supports within a local setting. There were some partnerships between gyms and education providers, including schools and TAFEs, and also some partnerships with disability like day services. There was a lack of partnerships between the gyms and any kind of rehabilitation service. And then the policy factors related to obviously policies supporting the development of inclusion programs, but also policies relating to who could or could not enter and work within the gym. So particularly relating to support workers and physios. So from all of the work that I did, one of the really big issues I felt was related to this gap in getting in the door. So how we support young adults with CP to actually connect and engage with local gyms in the first place. So for the young adults, there was those concerns about exercising in the gym environment and particularly that social environment of the gym. There was also issues relating to finding opportunities, cost barriers, and the young adults' self-reported knowledge or skills or confidence to commence gym exercise. And then at the other end, there is this gap in social support available and a lack of partnerships between gyms and the community, particularly therapists, that is impacting on actually connecting the young adults with the gym exercise to transition them into more of a community-based model. So based on that, there are 2 kind of key implications, and they are connected. The first one, I think, is about developing a partnership approach between the rehab world, being primarily probably physios and EPs, and the community gyms to help bridge this gap in getting in the door. So my studies identified a lack of communication and connection, and it does appear to be from both sides of the spectrum. There's also a lack of clarity on the role of physios in the gym space at the moment, especially I think since the NDIS has come out. Physios are obviously quite familiar with a lot of young adults with CP. We're quite involved in childhood, and now through the NDIS, there is much better access than there ever has been. And this new access really presents a lot of opportunities to develop our role in this space. And within the NDIS, physio is funded for capacity building. And so that's, I think, where we're really well placed to take on some capacity building roles in relation to gym exercise. So for instance, for young adults, we can support building their skills and their confidence and their self-efficacy relating to gym exercise. And of course, that includes things like how to use the equipment, which we probably already do, but it could also be more of a kind of health coaching approach about identifying their goals, being able to identify their own barriers and facilitators, and their ability to advocate for themselves in those community settings. I think we can also apply this capacity building approach to working with gym staff to help them develop their skills and their confidence in working with young adults with CP. And this development of gym staff skill was a priority to all the groups, including the physios as well. And then I think from the gym perspective, I'm not sure that they fully appreciate just how big this gap of getting in the door really is, or the concerns that young adults might have about gym exercise. To address this, I think gyms could work with physios to leverage the relationship that they've got with young adults and that trust that might exist within the rehabilitation world. So some of the policies around external parties like physios operating or working within the gym might need to be reviewed in a collaborative way. So having flexible policies that are more based on individual goals or individual need might be a better way than a blanket policy. So some young adults might need a much longer and a much more supported transition into the gym than others. And I think I did identify a potential facilitator for the development of these partnerships. And that's the inclusion coordinator role that operates in few gyms across Victoria now. So this role is a dedicated inclusion role where the person acts as a key contact, and they're the key contact basically for anyone who's interested in connecting with the gym. And so they could be a really central point for developing some of these partnerships. It was only operating in a couple of gyms, and they're not very well advertised. So I think there's a lot of room to improve the community awareness and the scope of those inclusion roles to help build this partnership approach. And then lastly, I think that we do need to look at across both the sectors developing some guidelines or some pathways of what a supported transition into the gym could look like. There are examples from other conditions like cardiac disease or pulmonary disease, where there are very structured pathways from rehabilitation settings into community gyms. So it just goes to show that those kind of partnerships and policies can be addressed to bridge that gap about getting in the door. And so there might be some opportunities to learn from those sectors about how those partnerships were developed. And then the last thing is relating to needs-based support. So through ongoing participation and also those early stages in the gym, we need social support that's going to meet the needs of young adults. Social support was really critical to facilitating participation across all of my studies. But what was also quite clear is that the support needs are very individual in preference for young adults, particularly relating to that one-on-one support in the gym. But in practice, what we see is that a lot of community gyms tend to offer a small range or sometimes just one type of support. And I think perhaps sometimes we do this in the rehab world as well. So as much as I would have liked to have, one great support that all gyms should offer, there really wasn't one. And I think that just speaks to the importance of trying to build the capacity of gyms to identify individual need rather than providing supports based on like a condition or a disability sort of type. And central to that capacity of the gyms is going to be the gym staff knowledge and skills in working with young adults, and not just in supporting their exercise, but their skills in being able to have conversations with basically, I mean, this applies to any patron, having those conversations about what support needs an individual needs. And I think that probably needs to be a priority for their staff training. So I'm going to finish up there. So hopefully we have some time for some questions and discussion. But then the next step, I think, is really to try and get these rehab and recreation worlds in the same room and try and work out this partnership approach. So might throw it out for any questions, if anyone has any ideas of how we could do that or what's next.